Good evening, all. This is our case meet 32, and as per our ISA City Branch Nanded, we started this case meets regularly on every Friday 8 p.m. And this is our celebration of Platinum Jubilee of ISA National and our Silver Jubilee celebration of ISA Nanded City Branch. So on this evening, we are inviting Dr. Sandeep Diwan, sir, is well known in USG guided blocks and uh, regional anesthesia. Sir is a consultant anesthesiologist and pain physician, and also pain physician. Yes, sir, yes, sir, yes, and academic director and head research at Sancheti Hospital, Pune. So this one is very short intro, but sir is very well known to us. And welcome you, sir, on this evening on our platform.
Thank you very much, Sachin.
Thank you, sir. Thank you. You can share now, sir.
Able to see?
Yes, sir.
So shall I start now?
Yes, yes. It's visible and very nice.
Yeah, okay. So this topic was given to me by Sachin. I had asked him to give a topic of my interest. So this I thought would be an appropriate topic to discuss. Now, this would like be a journey of mine from what I started in 1994, when we used to use paresthesia technique, and we used to just implement the supraclavicular brachial plexus blocks. In 1999, we started the neurostimulation techniques, and until 2012, and since 2008 until today, I practice both neurostimulation and ultrasound. Neurostimulation, particularly in workshops and in lumbosacral plexus blocks, while ultrasound practically in all the blocks. So, entire plethora of blocks have been practiced with paresthesia until ultrasound. So, outcome of the block would depend, I think, on the balance between the combinations you notice, and this is matters in clinical practice. I have chosen two models. One is the interskin, and the other is the lumbar plexus. So prior to 1999, the dictum was no paresthesia, there would be no anesthesia. And this was what Moore had stated in 1953. And there was evidence of the needle nerve contact in the form of this anesthesia was considered to be an art, where the practicing anesthetist is used to hunt for the nerves. So paresthesia was in relation to the nerve, the needle tip position in relation to the nerve, and this was a modality which was used this blocks and less commonly for the other blocks. And local anesthesia was injected 25 to 30 ml at that time. Paresthesia used to be in the area of shoulder or in the region of elbow, and this was considered appropriate. Many of these of the fracture of the occipital or the midshaft humerus done on blocks, and this was common practice in the
Dipen, any problem?
Sir is left, I think. Sir is having, I think, internet or issue.
Yeah, mostly internet problem maybe.
He's left.
Yeah, he will join, no problem. We'll join.
सचिन
हा
हॅलो
सर. हा सर.
सचिन स्पीकर काय म्यूट मोड वरती आहेत बहुतेक.
युट्यूब मोडवर आहे.
म्यूट आहेत बहुतेक.
नाही 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 सर, लेफ्ट झाले बहुतेक. ते नेटचा प्रॉब्लेम आहे सरांचा.
नेट इश्यू आहे का?
नेट इश्यू आहे.
ठीक.
हो, तेच मी
Sir is
सरांना
joined.
फोन
Sir is
करतो.
joined.
यस यस.
बर ठीक.
बहुतेक नेट इश्यू आहे, थोडा वॉइसचा प्रॉब्लेम होता.
बरोबर ठीक सर.
Are you able to see this, Sachin, now?
यस सर, थोडा वॉइस क्लिअर आता आला, एकदम क्लिअर, एकदम नो प्रॉब्लेम.
So intermittently, I think there's a problem.
यस.
So we were considering was paresthesia more effective because when we used to insert the needle close to the nerve, we thought that when the needle tip is close to the nerve, it does produce paresthesia, and the needle tip we are not sure whether it's intraneural or whether it's extraneural, but the chances of peripheral nerve injury were definitely there. So the dilemma was how far the needle should be away from the nerve, considering the paresthesia. So the challenging dictum was no paresthesia, no anesthesia, but often dysesthesia, because paresthesia is known to produce peripheral nerve injuries. And this is what was mentioned by another author in 1993. So this was a challenge to the original dictum of no paresthesia and no anesthesia. So until neurostimulation prior to 1999, only these blocks were practiced, and the axillary and the femoral was practiced through the perivascular techniques. So it was just like what this snow fox does. It does the presume and hunt. So it never knows where its target is, and it tries to hunt and trying to locate every time, and ultimately would find its hunt. So this was what was like the paresthesia technique in the past. So the limitations of paresthesia was I could not practice the infraclavicular, neither a lumbosacral or sciatic, though lumbosacral had used the loss of resistance technique. And this was all because of the rigid concept. No paresthesia, no anesthesia, but often failed anesthesia. This was what Morgan retorted to what Gentilini had said again in the same. Introduced the nerve stimulator in 1962, and this was though a crude form of neurostimulator. There was an objective evidence of evoked response in the form of needle to nerve contact. And this was now what art had turned into science. So after 1999, where I attended the first neurostimulation guided peripheral nerve block workshop in AIMS, this might be the first game changer. And then we started practicing the interscaling with neurostimulation. Now, this is the brachial plexus, and this is the cephalad side, and this is the cord side. And the injection insertion point, the tip of the insertion is somewhere at the level of the S5 and C6. It cannot be deep here at the level of C7, because close to this will be the vertebral artery. So the neurostimulation was inserted to the interscaling groove. And once there is a small click or a pop where the needle tip goes through the tip will be in the interscaling groove, and then you would start having contractions of the deltoid. This is the immotor spot. This when milliampere you inject your local anesthetic, and this was used for upper limb surgeries in the area of the arm as well as at the level of the mid-humerus. But what happened was when I did some devices, I found that with neurostimulation, the contrast, it goes right into the space and localizes the space. It does not go on to the opposite side, but it is there on the ipsilateral side. So with 20 ml of 0.5% bupivacaine, it was almost as an ipsilateral epidural. Ipsilateral cervical epidural with the neurostimulation of endoskeleton block. The next block is the lumbar plexus, where you try to inject your needle. Now, this is the swath which is reflected, and this is the entire lumbar plexus. And the needle tip has to be very close to that of the area, the towards the femoral nerve. At 0.4 amperes, you inject your local anesthetic. You get forceps response, which is a very important risk. And this is again an evidence that you are close to the femoral component of the lumbar plexus area. And when done that, you inject
Diwan
20
sir,
to 25 anesthetic.
Diwan sir, sorry to interrupt you. Diwan sir, slides are not rotating, and you are not audible properly.
Is it?
You are not audible properly. We cannot get your voice, and slides are not rotating. Can you correct the glitch? Hello.
I'm not sure why is this occurring. It doesn't occur anytime actually.
I don't know, sir. Dipen, can you correct it?
Yes, yes.
Now
Now
slides
moving,
are
sir.
visible, but
Yes,
your
now
voice
moving.
is breaking in between. Slides are moving now, but your voice is cracking in between.
No, but I'm not doing anything. I'm not correct. I'm not doing anything actually.
Yeah, yes.
It's working now, sir.
Now,
your
now
voice
it's clear,
Now
sir.
voice
Now
is
it's
clear, sir. Voice is clear, sir.
Yes. Continue, sir. Continue.
So should I go
Yes,
back
sir.
or it's
Yes,
okay?
sir. Continue. No. Continue, please. Continue.
Okay. So this was the lumbar plexus block with 0.4 milliamperes again, and you can see the contractions of the patella. This has to be an evidence based again. And this is at around 0.4 milliamperes where you inject local anesthetic. And most of the surgical procedures which were done in the lateral position, all these high-risk patients, we used to monitor with the Edwards for the cardiac output as well. Now, 15 ml of 0.5% bupivacaine, would there be any epidural diffusion? Almost we used to give 20 to 25 ml. This is a patient in the immediate postoperative period where we gave a lumbosacral plexus block, but you could see that he is moving his both the feet, and the quadriceps was intact on the contralateral side. But in 20 patients, again, we had this lumbosacral block with 20 ml of 0.5% bupivacaine, and we found the epidural spread. And this is the entire epidural spread that you can see over here in the lateral view, and in the AP view, it goes through the intervertebral foramen again into the epidural space. So again, what were we practicing? Was it the ipsilateral lumbar epidural? It's not cervical, it's lumbar epidural. But the block plethora increased. What we practiced was just the supraclavicular with the paresthesia technique. We now gave the infraclavicular, the lumbosacral plexus, the sciatic blocks as well. So what is the evidence for neurostimulation? Did it improve the block success? Did it decrease the complications? And what are the long-term safety effects? So the high success rate was noted by these authors, and it was all beyond 4% at the current that was being mentioned. The only dilemma was how far the needle should be away from the nerve. That is, once you get a motor evoke response, what should be the lowest current possible? So these two authors, the Andres and Franco, mentioned that the ideal current should be not less than 0.5 milliamperes. So less than 0.5, does it mean that it is intraneural? And how low is low enough? That is, how low current would be enough to produce adequate block, but not intraneural injection. So this is a study in dogs where they injected in live dogs who were being ventilated and spontaneously. This was at 1 milliamperes, and you could see the black dye, which was very close to the sciatic nerve. And this was again a red dye, which was close to the sciatic at 0.3 milliamperes. It means that from 0.3 to 1 milliamperes, there is no intraneural spread of the drug. This is the needle path. Now, if it is less than 0.3 milliamperes, so you can find the inflammatory signs in the peak sciatic nerve. And this is basically the epineurium, which has been invaded by the lymphocytes and the monocytes. Now, invasion of this after a needle to nerve contact, it means that there is a peripheral nerve injury. So the current cannot go less than 0.3 milliamperes. So this is one of the slides where one of the video clips where you can find the intraneural lumbar plexus needle placement. Now, with the quadriceps contractions at with the quadriceps contractions at 0.28 milliamperes, you will see that the needle would be now intraneural. So this is not accepted at all. The needle has to be always placed with the current more than 0.4 milliamperes. Now, Greenblatt, who had introduced the nerve stimulator, he found that the local anesthetic volumes reduced 4 ml, 1% for femoral, 8 to 10 for the sciatic, and 15 ml for the axillary block. And this was as opposed to paresthesia, where they used to have injections of 10, 20, and 40 ml respectively for this. Surprisingly, if you look at the figures now in the literature, you'll find that these are the figures which have been used for ultrasound. But the complications which were related to nerve stimulator, they persisted, like the intravascular injections, inadequate blocks, and sometimes the inadvertent wrong spread of the drug. So do we support the use of peripheral nerve stimulator? Yes. Whenever the patients are less cooperative, there is a language barrier. Definitely, paresthesia gives a lot of discomfort than the PNS. And you can have a continuous feedback and needle adjustments. Like, for example, you have the contractions at 1 milliamperes, and you go down to 0.4, you advance the needle, and again, you increase the current or decrease the current based on the type of contractions you have, like if it's mild, moderate, or severe contractions. However, at 0.4 milliamperes, you should have some flicker of the contractions. Now, this was the beginning of the ultrasound. This we call as the newcomer, and this was in 2007, where you see growth of the literatures of the ultrasound, and there was a gradual increase in the ultrasound citations starting from 1998, and it went up very high. And this was the period where we have maximum number of articles in the literature, though the sales growth of the PNS, it still continued. It means that the ultrasound was a new modality, and it was catching up with the peripheral nerve stimulator in this particular era. So post 2008 now, I attended the World Congress in Brazil, and this was by Vincent Chan, and we were just 4 delegates, and we looked upon with awe that the ultrasound was being demonstrated as a modality for nerve blocks, and this was something very peculiar and something very different for all of us. Now, coming to the scaling, now this is a cross section this is of the Thiel-based cadaver that we did in Graz in Austria, and this is the middle scalene muscle. Now, this is the C5 with all the fascicles. That is the C6 with all the fascicles, the C7, and the C8. So basically, when you look at ultrasound picture, what you see is these are the roots, what you see, and they form the trunks later on, and they form the divisions. So here you'll find what are the brown ones are all the fascicles. These are all the fascicles, while this area is all the connective tissue. That means this is the most safe zone. But would you like to go beyond this? Now, this is the epineurium of the C5, that is of C6, and that would be of C7. So are you going to go beyond this? So what when we used to do with the paresthesia technique, we used to almost penetrate the epineurium, and it would be all subepineurial injections. But with nerve stimulator, we came very close to this, and we may have not or may have injected beyond the beyond the epineurium. So with ultrasound endoscreen, now you can see that this was by Vincent Chan in 2003, and you could see these are some of the fascicles that you see which correlate with what you had seen earlier. And this is the exact path of the local anesthetic that goes around. And this, at that point of time, they used to inject they used to inject anterolateral and also inject posterolateral to the brachial plexus. So there are four things you could see: nerves, vessels, needle, and local anesthetic spread as well. Now, this was in 2007, and this was when I started my ultrasound practice. And you could see that all these hypoechoic nodules, what you see, are all the nerves. This is the artery, that is the anterior scalene muscle, that is the middle scalene muscle, and this is the ribs. So I could see the entire brachial plexus here. But what the problem was? The problem was we did not adjust the depth, and we did not know the whether it has to be inside or outside the white thing that went around, and that was supposed to be the epineurium. And we did not know what type of needle had to be used. So these were routine needles. They were not echoic needles. They were normal needles which we were using. So these were some of the problems that we faced. So when I used ultrasound as the first time and the image intensifier as the second arm, I found the needle placement was exactly in the brachial line, which joins the C6 and the midpoint of the clavicle. Now, one important thing was the surgeon's feedback, because we never decreased the volume of the drug. We found that there was unusual prolonged surgical analgesia and surgical anesthesia as well. And what were the red flags? It was the needle intraneural or was the injection intraneural? Because we found that we had these two important problems. So what are the structures the needle should penetrate? This is very important. Now, if you see this, now this is the entire epineurium of the roots, and these are the fascicles. Now, it is very safe to insert your needle in this particular area, and this is called as the safe zone. And this is what we routinely do in our clinical practice with ultrasound. And we never go below the epimysium. So there are no sub-epinural injections. They are all paraneural injections. This is very important and very clear to us. So if you look at the roots now, for example, the C5, C6, and the C7, our needle placement would be exactly in this area. And it would be never in this area, never in between these two. Though it was practiced in the past, I confess that this was called as the intraplexus, and this is called as the periplexus. So it's important to inject in this area and not in this area. So if you get the needle now here, and we look at the current, maybe it is 0.4 milliamperes. So we add the current might drop to 0.2 milliamperes. And if it had been somewhere here, it could be somewhere around 1 milliamperes. But it's always not necessary to have all these things. Sometimes they might interchange. So you have to be very, very cautious in that case. So what about the needle nerve proximity? And this is what we exactly discussed, how close is close enough. And so now these are the safe zones. with ultrasound technique in the interscalene block, these are the very safe zones where you can insert and inject in these areas. So some of these surgeries like the proximal humerus, we do with ultrasound guided, and there is a problem of muscle relaxation. Some of our surgeons may not be entirely happy with the contractions of the deltoid. They say that and might have to cut a small part of that muscle. And but however, post-operatively you will find that, or intraoperatively you'll find that it's a very site-specific surgery where the patient can move his or her hand as well. So the volumes of interscalene block, they significantly came down with the anatomical landmark where 50 ml was used to 20 ml with neurostimulation to just 5 ml with ultrasound. And the complications of the high volume, the phrenic paralysis, the total spinal and total epidural, it just came down with the neurostimulation to phrenic nerve and lateral epidural, and to almost nil with 5 ml of ultrasound guided. Now, Philippe Gauthier has used this for surgical procedures, and he kept his patients awake with 5 ml. But I'm a bit skeptical about the 5 ml volume in AVIC for AVIC patients. Now, this is another article which mentions about the epidural spread and the phrenic nerve paralysis with volumes which were compared between 20 and 5 ml. And what they found was that the epidural spread was both with the 5 ml as well as 20 ml. But the phrenic nerve was blocked more with the 20 ml and less with the 5 ml. So the least volume that can block the phrenic nerve is just 5 ml. I use proximal humerus in patients who are frail, more than 80 to 85 years, 8 to 12 ml of 0.5% bupivacaine. And adult 60 years, I use 15 to 20 ml of 0.5% bupivacaine. Now, this is one of the articles that we published recently, and this is low volume, but this is used only for analgesia, where we use not more than 5 ml of local anesthetic, and we've had a good success for almost 24 hours until the patient were discharged. So how is ultrasound? Ultrasound is like you look at the target and you just have to knock it down. So this is what the ultrasound looks like against what the neurostimulation looks like. So looking at the target is very important with ultrasound, and then needle directly in the path of the target. And this is what is the ultrasound is. So what more did we see? We saw the nerves in the middle scalene muscle, location of the phrenic nerve, vasculature in the posterior triangle, and anomalous cervical root. 4 important things which will make the block more efficient. Now, the plexus dissection, the trunk, and these nerves are all in the middle scalene muscle. The spinal accessory is most posterior along the trapezius, the dorsal scapular nerve, and your nerve path is exactly, it goes through this and it will be close to the superior trunk. And this is the reason why you need the neurostimulation to understand where exactly you are if you're not able to find these nerves. But these nerves can be located with ultrasound if you are sure enough. But if you're not sure about this, you might have to use neurostimulation. For example, these two are the ones, this one coming from the C5, this one coming from the C6, that's the posterior tubercle, that's the intervertebral foramen, that's the anterior tubercle. This nerve has already come out. This is the branch. This is another branch which is moving and going more lateral through the middle scalene muscle. So if you are able to understand what exactly and where exactly these nerves are, you can easily then target this particular area, and or you can target through this area, and you can avoid going directly through these particular nerves. Now, C5 variation. Look at this nerve, which now is this is what I'm trying to show you. And this is one which moves around the anterior scalene muscle and then comes in line with the brachial plexus. Now, if you can see that if I move the probe more cephalad, you will find that the C5, it moves away from the brachial plexus and it goes away. So now this is the path of the brachial plexus. So if you are doing a neurostimulation brachial plexus block, this is definitely going to be not targeted and not soaked with local anesthetic, and it's going to escape the needle path. So this is the reason why sometimes the neurostimulation would be required if you're not getting a definitive brachial plexus. Now look at this particular slide. You will find that if you insert your needle and you don't see anything below the level of the skin, and you will find that the whole of the interscalene groove is empty. You don't find anything. You find just one thing here, that's the C5. You find the another here at this point, and the another here, the C7, and the subclavian artery there. So you would be so much frustrated that you won't find any neurostimulation or evomotor responses after you insert your needle. Now, sometimes when you insert your needle with neurostimulation, you will find bloody aspirate. This is basically because of this particular structure, which is the dorsal scapular artery going in between these two trunks or the divisions. And we're trying to find the incidence of vascular structures, though it has been studied already. We are still trying to study in a large group of patients. And this could be the reason for the bloody aspirate or post-block hematoma. And this could be the reason why ultrasound would be more beneficial in these cases. Now, this is a cadaveric cross-section of the lumbar plexus. What I'm trying to show here is this is the transverse process, and going above is the vertebral body there. This is the psoas major muscle, and these are the roots. So this is the spinal cord, and the roots, they come out and they go into the psoas major to form the lumbar plexus, and this is what we are targeting here. Now, this could be the lumbar paravertebral space, while this could be the lumbar plexus area. So I usually do the ultrasound lumbar plexus with neurostimulation, while in 2001, these authors, these are very good authors from the and in Austria, and they did a cadaveric and voluntary study, but they could hardly find the lumbar plexus. It was 0% in 2001. At the same time, in 2009, sometimes 8 years later, I used to do the lumbar plexus with the shamrock, which is now called as the shamrock technique. But unfortunately, I did not publish. Shamrock came in 2013, while I used to do it in way back in 2009. And this is what is the transverse process and the vertebral body. What you find here is the kidney over there. And this is the needle which is coming from the posterior. And we are trying to target this area, which is the posteromedial quadrant. But again, you can see the depth. We don't see the neural target, and we were very high for the level of the block. So this was in 2013 that Sauter had mentioned about the shamrock technique with the ultrasound and neurostimulation. In 2013, it was the lumbar plexus, which was visualized at 57% only with the ultrasound, while in 2015, again, lumbar plexus at 66.7%. And he could also look into the needle to nerve contact, and he could also identify the local spread. The local spread is not that as good as what you can see in the interscalene area. This is just to show the sonolumbar plexus, what you would be seeing in the sono anatomy. We are looking on the lateral aspect. Now, this is the transverse process, that's the vertebral body. This is the lumbar plexus, and that is the psoas major. So your needle is going to come from the posterior, and we are trying to push your needle right into the lumbar plexus area. Now, this is the sono anatomy of plexus, and what we're going to see here is the transverse process, and the vertebral body is the same as the transverse process and the vertebral body. And this is the hypoechoic area where the local anesthetic has been injected. And what you see is the hyperechoic is the lumbar nerve root. So this is what exactly you see in the cross section as well. Now this is the live lumbar plexus, the needle coming from the posterior. You can see the needle tip close to the transverse process, and then it goes just beyond that. This area will be the lumbar nerve root, which you're trying to uh, get to. And once you do that, you get quadriceps contractions, and then you inject your local anesthetic. Now, this is the local anesthetic which is being injected. You can see the hypoechoic area, which is now getting more larger and bigger and bigger, and you can see the lumbar nerve root right inside the hypoechoic area. So this is a real-time lumbar plexus block. So where would your needle tip position would be? So we did ultrasound as the first arm, and I and the image intensifier the second arm. We found that it is lateral to the spinous process, and it is in front of the transverse process, and it is very close to the lumbar nerve root as well. So we again identified the lumbar nerve root with the help of neurostimulation at 0.4 milliamperes with quadriceps contractions as the endpoint. So the needle tip again has to be very close to the nerve, but should not be intraneural. So this is the intraneural, this is all the extraneural, and I am sure that you won't be able to see this kind of structure with the ultrasound. This is a cross section, hence you can see this in the lumbar plexus area. But definitely you can see this, you can differentiate between fascicles and the connective tissue in the interscalene area as well. So what more did we see with ultrasound? We saw the posterior medial quadrant where the lumbar plexus lies, and the lumbar segmental artery, which is close to the lateral vertebral body. And we also identified the lower pole of the kidney, which is important to identify the level of lumbar plexus block. So this was again an article that we published to identify the nerve. Now, this is the intervertebral foramen. This might be difficult for some of you to understand, but this is the nerve path which comes out and goes into the psoas major muscle. We were trying to identify where exactly we should place the needle tip. If you place it further away, the flow would be more distal, but if you place it close to the foramen, it will produce more of epidural spread. So this is what we try to understand by placing the needle tip positions. This is the psoas, the whole is the psoas major muscle. That's the lateral vertebral body. And this is the posteromedial quadrant. And the lumbar artery lies very close to this, and lateral to that lies the nerve. So you will always find the nerve, which is lateral to the artery, and the tip should be again lateral to the nerve. So this is very important in lumbar plexus blocks. So the volumes, whether did they reduce from 30 to 40 ml, we came down to 15 to 20 ml with neurostimulation, but it is still the same with ultrasound, which was by Sauter in 2015. We had incidences of total spinal and epidural with the 40 ml local anesthetic. And we had this event with the 15 to 20 ml, and we had uneventful epidural spread. So the dual modality, often you need to combine the two. For example, like these patients, obese patient who was weighing around 140, and he had a history of obstructive sleep apnea. So I injected 12 ml of 0.5% bupropion, combined it with the neurostimulation, and finally placed the needle tip very close to the C5 and C6, and we got a good block eventually. Some of these patients underwent lumbar plexus block. Now, this was the patient where you find this is the iliac crest, that is the posterior superior iliac spine, and if you see the needles passing through this was the point of needle insertion, but I could not get needle. This was a big failure. I went for the cap development, but this was a failure. For the decrease point, again, this was a failure. So after failing for a couple of times, I used ultrasound by placing the probe here. I found the lumbar plexus, and then I neurostimulated at a high level, but the lower pole of the kidney was very close to this. So that was the problem in this particular patient. So what is the evidence for ultrasound? Ultrasound versus neurostimulation, they found with specific primary outcomes, no further studies were required because they found that the ultrasound was better than the neurostimulation. Now, two meta-analysis considering the block efficacy, they had a pooled data and they found that there was the block efficacy had increased with ultrasound. But you need to be cautious about the results with pooled data, of course. But eventually, there is evidence that the ultrasound is always better than the neurostimulation. Another evidence with the randomized controlled trials, when they found that the ultrasound was better than neurostimulation. So now there are no further studies carried out because it has been established that the ultrasound solo is better than the neurostimulation solo. Also, with increased resolution and fairly a decreased cost, there are no further arguments in of both the factors. And there are increased number of workshops and CMEs on ultrasound now. I recently conducted in Hubli, Dharwad, where we had almost 120 delegates, and all of them were postgraduate students. So we have moved from clinical to more research area as well with the ultrasound, because we are now finally seeing things and we are finally trying to assess what we are trying to evaluate and trying to analyze many of these things. Now, one of the quality assurance database has found that the peripheral nerve injury and the last, they have gone down with ultrasound and neurostimulation. If you combine these both, you can definitely see a decrease in both of these complications in a fairly large group of patients. Now, this is one of the largest studies where they have done more than 25,000 peripheral nerve blocks in 20 hospitals. The overall complications of last was 0.87, of which 2.1 were with neurostimulation and 0.1 with 0.5 with ultrasound. So there was a decrease by almost 65%, which is a huge number. So definitely ultrasound has helped a lot, and if it used with the neurostimulation, it would be more beneficial to the patient. Now, whether the ultrasound has decreased the volumes of local anesthetic, they have found that with neurostimulation, where they use 5.4 ml, it has come down to 0.9 ml. Now, this is a clinical study, so this has not to be taken into a clinical practice. So a study would be different from a practice, and I still use around anywhere between 15 to 18 ml in adult patients, but if it's more than around 70 to 85 years, I use sometimes in very frail 8, but maximum I would use 12 ml of local anesthetic, which would benefit the patient in the form of clinical outcomes. So the lowest volume that was used by these authors was 7 ml of 0.75% bupivacaine. Now, this is a very high concentration with a low volume combination. We recently published this in IJA, where we used 3 ml of local anesthetic with a continuous catheter technique under ultrasound, and finally placed it in interscalene groove. You can see that it is finally placed in the interscalene groove, 3 ml. When you give 6 ml, it spreads even more. And when you give around 9 ml, it still further spreads more. So what we did was we inserted catheter with the patients who had these kind of injuries and who had to undergo the proximal humerus. We tunneled this catheter, and after insertions, we gave 3 ml. We had specific outcomes. We gave 6 ml, and then we gave 9 ml. If with 6 ml there was no anesthesia, then we gave 9 ml. We found that these two are quite good enough in very good enough in this particular case series. Now, with ultrasound lumbar plexus, did it reduce the dose? We have not found a reduction in the dose. It is same as what has been in neurostimulation. And in fact, the ED95 was 36, while the ED50 was 20.4. In Indian population, you can use around 20 to 22 ml of local anesthetic for the lumbar plexus blocks. This is just the study which was carried out. They found that the 20.4. So what they do is that if they go for a low dose, if it fails, they go for a high dose. And then again, they come down on the dose and try to see the lowest dose where again it fails. Then they go for the high dose and then they calculate the exact volume of local anesthetic that would be adequate. So far in lumbar plexus blocks, the ultrasound is equivalent to neurostimulation. Now, these are the studies by these two authors recently, while these are the studies from 94 to 2005. And we found that almost 20 to 25 ml of local anesthetic is given in both these groups. This is the author who published where he finally says that it is, even with ultrasound, it is difficult to visualize the lumbar plexus. The skin to target needle depth varies with the body index. Neurostimulation is 0.3 to 0.5 milliamperes if not visible with ultrasound, and more than 0.5 milliamperes to prevent unintentional needle to nerve contacts. So what he mentions is that you use for lumbar plexus is ultrasound with the peripheral nerve stimulation, and use more than 0.5 milliamperes in high body mass index, and less than around 0.5 milliamperes with the mild to moderate body mass index. Now, the shamrock technique is always superior to all these techniques that have been utilized, and though there has been an epidural spread, and there is only one case of a local systemic anesthetic toxicity, the shamrock technique is supposed to be better than the other techniques that have been described in the literature. Now, one of the important things what always struck me was the lumbar plexus block has been studied in the adults, and it has been successfully visualized. But what about in the aged group or in the elderly patients above the age of 80 with comorbid situation where you really require the lumbosacral plexus block, which is in fact is more hemodynamically stable. So it's really difficult. If I put this picture in front of you, you might not be able to say what exactly this looks like. But if I try to decipher this, this is the transverse process and this is the vertebral body. And what you see here is the psoas major, and you don't see the nerves. So what you see is a degenerative calcified psoas major, and there would be again the hyperechoic nerve, and there would be a change in the paravertebral topography because this has become convex because of certain reasons that affect the elderly patients. So we published this where we had failed ultrasound in several case series in elderly patients because of all these important factors. We found that sometimes the lateral vertebral body is concave, sometimes it is flat, sometimes it's convex, and it will all change the topography of the of this posteromedial quadrant where you target the lumbar plexus. And this is very important for us to understand. And you always require neurostimulation in these particular patients. So like coming to the end, the final verdict in my opinion would be ultrasound plus neurostimulation in obese patients for deeper blocks. Ultrasound only can be used in moderately or slim patients or without the neurostimulation endpoints. And ultrasound only can again be used in thin build patients and superficial block in anticoagulated patients. Now, today I used a patient who was on clopidogrel, and he had a normal INR, APTT, and PT, and he underwent for proximal humerus under general anesthesia with ultrasound guided intrascalene block. So these are the patients in whom this could really benefit. So this is the patient, obese patient, whom we discussed around age of around the weight of 134, 12 ml of 0.5% bupropion, and you'll see that this is the patient a proximal humerus surgical procedure was done. And at the end, he did quite well because he had a history of OSA as well. And this was done combined peripheral nerve stimulator with the ultrasound. You could see the deltoid contractions in the previous video clip as well. And this is the intraoperative just after fixation. It is how site specific is the interscalene block with just around 12 ml of 0.5% bupivacaine. And they can produce all the movements of the hand as well. And the surgeon also feels confident enough that there is no neurological damage. Vigilance is very important in these cases because you have to focus on the ultrasound. You need to focus on the contractions. You used to focus on the pressures when you start injecting the local anesthetic because we don't have a transducer there. So it all depends upon your clinical judgment. So these are important things that you need to be taking care of. With the lumbar plexus, again, with the ultrasound, you need to have a neurostimulation. It has to be a dual modality in these cases. And these are the deeper blocks, though the elderly patients, they are thin. Sometimes you may not be able to get hold of those nerves. Ultrasound definitely helps to direct your needle to the posterior medial quadrant. And then with neurostimulation, you can achieve quadriceps contractions and inject your local anesthetic. What we are trying to do is reduce the volume to 0.2 ml per kg from 0.4 ml per kg. And I did certain, about the age of 90, I did some contrast studies. I found the contrast going very close to the lumbar plexus. You can see it going medially, posteriorly, and laterally. So actually the nerves, they arrive through the intervertebral foramen, and then they go laterally, and then they exit from this part, and then they go into the fascia iliaca zone. So if you look at the coronal section, this is the part where is the path of the femoral. So we call it as the femoral nerve pathway. And this is the path of the obturator, where we call it as obturator nerve pathway. So you have different pathways in different areas. So even with very low volumes in elderly patients, this is blocked because the psoas major is atrophic. And this is important to understand. Here, the psoas major is atrophic, and the nerves, they lie very loosely in the lumbar plexus area. So this is all what I have from my side, and I invite you to this particular conference, which will be held from a month onwards, and we are having excellent arrangement for the cadaveric workshop as well. And this is on the 2nd August. The seats are filling fast, and this is about the entire AORA, which is in Mumbai. So I welcome you for all for this particular workshop. Thank you very much, Sachin, and I say Nanded for this particular invitation. Thank you very much.
Thank you, sir. Thanks a lot. Very knowledgeable thought you shared with us, and you are the one of the most best expertise in this field. And we are conducting this case meets as a private forum for remote places like our Nanded, Parbani, Hingoli, Marathwada places, or any Maharashtra places. So maybe we don't do regularly these sono-guided blocks, but we are doing PNS at least nowadays. And this one is a very eye-opener for us.
Yeah, so Sachin, this is a very nice initiative that you have taken, because when I started my neurostimulation practice, I have been to Nanded, I have been to Yavatmal, the entire area, the entire belt, from Nanded, Yavatmal, as well as which is that place, Datta Hospital. So, and then Savangi, and then in Nagpur. And I conducted workshops in most remote areas where we had delegates who were not huge in numbers, but they were really very much interested in these nerve blocks.
Yes, sir.
And it's very nice of you to take this initiative. And IISc Nanded was the first branch to invite me way back in 2002 when they had this state
State
conference.
conference, I think so.
Yeah. Yes.
Yeah, CME also.
Yeah, correct. So that was a very nice of all those present during that time.
Really, hats off to you, sir, because you did a very good work. And I'm the junior of Dr. Abhijit Nair. He is
Oh, is
my
it? Yeah, 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 yeah.
yeah,
So,
yeah. He's
so
my
Dr.
senior.
Abhijit Nair is my academic colleague, and he is one of who has inspired me into putting all my efforts into publication. So now I'm busy doing that
Yes.
along with him, and we have got an academic group where we have a lot of people around, and we have Divya Sethi from AIMS, Archana Arati from Puducherry, then we have so many people like Medha Kulkarni from Aurangabad. Then we have who else? Uh, Abhijit Nair is of course there all the time with me. Rasika is from Nagpur. Yeah, and Pallavi is from Pune. Shiva Shanmugam again from Puducherry. So we all usually have conversations during our but most of them now are related to ultrasound, Sachin, because we have progressed a lot in ultrasound. Do I still consider peripheral nerve stimulation as the one which has taught us many things, which the ultrasound would never have taught us. Most of the newcomers, postgraduate students, would like to go into ultrasound immediately instead of understanding the anatomy. So I would urge them that if you have, even in private practice, like when I was in Miraj, I used to attend uh, the cadaveric dissections in anatomy halls. So if you have something like that there, uh, few of you can really go into and you can try to assess the and evaluate all the cadaveric sections or dissections. Try to understand the anatomy. That would help in a long way. Sachin, I think this has to be taken into consideration.
Yes, we at remote places we do blind blocks which are the away from decades, and we do that as a skill. And you are one of the photos when I discuss with you. I need your photo.
Yeah,
That time I realized one of the photo with you that there is mention that technology kills the skills of the professionals.
yes,
Like that, something was there.
right, right.
Can you elaborate on that?
No, no, no. What I'm saying was, see, people, postgrad students are in a rush to perform ultrasound guided blocks
Yes,
without
sir.
understanding anatomy.
Yes, yes.
Now, the cadaveric anatomy forms a very strong base, and you need to visit this, and you should try to understand. Like for example, now if you insert your needle through the middle scalene muscle and try to position it close to the interscalene area, you should go into the cadaveric sections and dissections and try to see how exactly that needle is going through the middle scalene, what structures it's coming across, where you would be positioning your needle tip. So all these things comes into practice only when you start looking from the very base. So anatomy forms your base, and this is exactly the reason why I was invited by the European Society of Anesthesia in Bilbao in Spain 2 years back, where I was given 6 lectures, and one of them was on cadavers, and the rest of was all 5 were on anatomy. Fortunately for me, I have very important anatomists with me. George Spiegel from Austria now is in Germany, and Xavier Sala from Spain, and Shiv Prakash from Mysore, JSS. Most of the slides and in my book, I would be incorporating what we did in JSS Mysore, and they form very important base. And we do a lot of cadaveric studies there. Yes.
So you mean to say we have to attach with institutes for anatomy dissections, and you should check the anatomical nerve
Yes.
roots and their paths.
Yeah. Why
Then
not?
only
Yes, why not? So, see, if you have an anatomy department there, why not take opportunity? If you for who are hardcore regional anesthetists, why not visit they would be eager to accept you, because wherever I go to conduct these cadaveric workshops, people are eager to help you out. People are eager to understand what exactly you would like to have. You could have a very good interaction with them. So I would urge everybody of you to practice this cadaveric. I mean, you should be
Should
attending the cadaveric.
attend that.
Yes, yes, yes. I would urge that.
So, so I will also appeal on a behalf of Dr. Diwan sir that we should attend our nowadays that our government also setting up new medical college in every district.
Yes,
So you
yes,
can you can go at anatomy dissection hall and you can see the nerves you are blocking.
yes.
At least you can see that and you can able to see at that places easily.
The problem with the cadavers now is most of them are formalin based, so you may not be able to easily visualize the nerves with ultrasound, and you may not be able to insert the needles because the skin and subcute become very thick. We now are looking for soft embalm cadavers, which we have now in MGM workshop. They are fairly good. We had that in JSS Mysuru, where they were also really good, and we had that earlier also. So we are now looking more into the soft embalm cadavers rather than the formalin based. And more than that, we'll be looking into fresh frozen cadavers. So as the anatomy department progresses, uh, we will be having a good quality cadavers. Yes.
So, like surgeons, they also needed anatomy dissection halls for their surgeries. So
Yes.
we should also enter in the anatomy dissection halls in future.
Yes, I have been doing that for last 20 years now. So I think it's time that everybody should incorporate that in your clinical practice. So why not make a team of your original anesthesia and you visit them in maybe in a month, or maybe twice or thrice in a month, and that will help you to do a lot. You take needles along with you. You may take you cannot take ultrasound, of course, but you can take needle along with you and try to understand the needle position along during the cadaveric dissections. And if they have cross sections, it's worth. Like for example, if you have a cross section, what I demonstrated, you can keep the needle and then you can exactly see how it goes through all the tissues and all everything. So it makes
So,
sense. It gives you a three-dimensional view when you do that.
so you feel perception and then you feel the what you say that practically you are working on in OT and in dissection hall you
Yes.
feel something like that.
So
So
yes, so you tell me if you visit now, maybe in a month, maybe this month if you visit, and then you can tell me in a month's time whether it has definitely helped you. I mean, garnering your skills in peripheral nerve blocks. It really improves a lot.
really helpful talk on a lot of things you did. You learn and you are sharing with us. This is one of the best thing, and we are most welcome for this for all private forum practitioners and doctors that you can learn from these stalwarts. So I'm very much thankful to you, sir. In this evening, you came on our platform.
Thank you very much, Sachin. It was nice of you to invite, and it was nice for me to share with you everything, whatever I could have with me.
So I will ask to all participants if anybody having any question to sir can ask in question and answer box. Sir, overall, your epidural or era of nerve stimulation and blind blocks. You did blind blocks before era of nerve stimulation?
Yeah, I showed some slides from 94 to 1999. I
Yes,
was
yes.
doing paresthesia technique. So this was in two places. One was in Miraj and the other was in Gondovli. So I used to go there as an anesthetist for that's a charitable trust. So we used to practice a lot of blind blocks there. So this was more commonly the supraclavicular blocks, and sometimes with loss of resistance, the lumbar plexus and perivascular for the axillary.
So I feel that when you did that blind blocks and you came to sonorized blocks, in between there is PNS.
Yes.
So what you feel that blind blocks that works when you give that time you're feeling, and nowadays when you give sono guided blocks, what is the difference between this era?
Yeah. So I agree with you. In fact, I showed you that video where the snow fox it hunts the
Yes, I.
below the surface. So that was like what was paresthesia. And the other where you could see the insect being knocked off by the stream of water. So that is like ultrasound. So you're seeing things now. So that it makes you more a perfectionist. Uh, Before that, the parasite technique, yes, it was like you hunt and peck and hunt and peck. So it was all that. So that was a different era totally, where you used to enjoy the blocks with very limited resource at your hand, just a needle, and then you keep on hunting for the nerves. But now you have ultrasound, definitely with a high volume of cases like what we have in Sancheti Hospital now. So the time limit is very, very small. You need to give surgeon the patient very fast, and you have to be very quick. And sometimes we are alone with the technicians, and so uh, so that's the difference. Previously, the duration was to make the patient ready was more than what we have now.
Sir, sir, one question from Dr. Nasima Akhtar in chat
Angio-abdominal
box.
block, do you practice which one, which
Yes,
type of surgery? Please elaborate. So we don't have much access to abdominal surgeries, but we have polytrauma patients where I usually give subcostal block along with the tab block. Bilateral, I use around 80 ml of 0.1% local anesthetic. There may be no role of clonidine in this case, but the patients are really uh, pain-free in the immediate post-operative period. Of course, it's along with the multimodal analgesia. So no rectal sheath block, just the subcostal and tab blocks. Bilateral 80 ml of 0.1% ropivacaine.
sir. In one slide, you told about the relaxation of muscles in humerus splitting. You mentioned
Yeah,
about that.
so the deltoid muscle somehow, though it receives its supply from the axillary nerve and it's blocked at the level of C5, C6. In spite of that, we find that the deltoids sometimes are very taut, and this could be basically because of the patient habitus. In elderly patients, we don't find that. In some of the patients, if you palpate the other side of the deltoid, they are quite soft. So in those patients, you may not have the problems of muscle relaxation. But in some heavily built patients, yes, we find those problems, and the surgeon really has to struggle. And sometimes we might have to convert them into general anesthesia with a supraglottic device. No need
Other
of
than
muscle relaxation.
yes, sir. Yes, sir. Other than GA and any methods you use for.
Yeah, I have used cervical epidural, but I don't recommend that on a routine basis.
Okay, sir.
This was in the past, and this we have also have uploaded one article where I've used stimulating catheter in the cervical epidural space, and we use it just 5 ml of local at the level of C5, C6 after stimulating the deltoid and the biceps with the catheter in the epidural space. So that is one of the alternatives, and we find that the volumes are less and the relaxation is more better than in with the interscalene blocks.
So overall, your blog experience is one of the best you did almost in ortho surgery. But in general surgeries, there is a lot of work. They need relaxation in for every. It's almost laparotomy like that. What do you feel? Which drug is best for a relaxation point of view as a local
So
anesthetics?
As
in
a local
blocks.
anesthetic, yeah, as a local anesthetic, in the past in Miraj, I used to use a combination of lignocaine and bupivacaine. We used to give thoracic epidurals at the level of T5 and T6 for abdominal surgeries, upper abdominal surgeries. And during, if the surgeon wanted a relaxation, I used to inject plain lignocaine at that time, just for the relaxation. And bupivacaine was then continued once the lignocaine was injected. So this was the combination that I used in the past.
Nowadays, I think
Nowadays, no.
you
Nowadays,
don't need.
yeah. So nowadays, we don't have these surgeries done in our hospitals. Though polytrauma for laparotomies, we use more of general anesthesia along with the abdominal plain blocks.
Yes. So overall, what I want to say is something that before you are using locks and bupivacaine, we also use in Nanded. Nowadays, levoanamine is introduced for us, and we are
Uh-huh.
using for this segmental blocks, and we are routinely doing giving this. And there is somewhere there is relaxation problems happening, and even they shared us that you can use it for blocks also. You use it levoanamine
No, no. Leoanavin for epidural or for
in
which
for
surgery?
blocks purpose, block purpose.
So you don't find it good? I mean, the block efficacy, the motor block and sensory block.
Yeah, it's good. But what now recent updates I need with you that
No,
ropivacaine
no,
is
no.
good or levobupivacaine is good for blocks.
So I'll tell you what. So I've been using lignocaine and bupivacaine for a very long time. I have not changed this mind in practice. I
Okay,
use ropivacaine only for post-operative analysis because it's very safe. Even if it goes intravascular 150 milligrams, I'm not I don't have any
bothered.
problems there.
Yeah,
Yes. But this what you mean is leobupivacaine.
yeah, yeah.
That I have not used. So recently they had a few samples which were given to me. I have not yet used, but I'll be using it shortly. I will let you know about this.
So one thing I heard in some literatures that you use short acting and long acting equally
Combination
in
of both.
combination of drug.
Yes.
Someone says that short acting will act on nerves, then long acting will not act on drug.
Hmm.
It's not useful. It are better to use short acting or better to use long acting only. What do you experience or what is your thought on this?
It's no, no, it's not, it's nothing like that. Lignocaine and bupivacaine, if you compound it and if you give it simultaneously, it does act. There's no problem at all. Even if you give it separately, it does act. There's no problem at all. For those who have not read, they have to go into the details of the blocking properties of lignocaine and bupivacaine at the ionic levels. Only then they will be able to understand how they act and what happens if you give it separately or if you give it combined. And there is a very good article by Gary Strykarts. He's called the father of local anesthetic. I think you should read his articles, which he has done. He has got his own lab on local anesthetics, and he has done a lot of work on just on local anesthetic and nothing else for almost 25 years.
Sir, please share with me on WhatsApp. I will share with our colleagues
Yes, I
on
will do
this.
that. I will.
This is a hot topic in our branch also.
Okay, I will
Yes,
definitely do that, Sachin.
yes, yes. Sir, really, I will conclude this session. I'm
Yes.
very much happy that on very short notice you came on our platform in your busy schedule.
Hmm.
I'm really happy. One question from Madam, Dr. Naseem Akhtar ma'am asking in chat
Yeah,
box.
you can use ropivacaine. There's no any contraindication to that. I don't use because I have not been using for a very long time. 20 years I have using bupivacaine, so I'm happy with it. And I would use only in the post-operative period. Ropivacaine 0.5% or 0.75%. Yes, you can use it for even routine anesthetic techniques. That should not be a problem.
So I mean to say you are happy with lignocaine and bupivacaine.
Yes, absolutely.
So still you use lignocaine in blocks, that this is short acting, what literature mentions,
Yeah.
and it's acting what point of view with it, with any, you add any adjuvants with this?
So adjuvants, we add clonidine 1 mic per kg body weight. I don't use dexamethasone. I use dexmedetomidine, but that's for only for the study purpose.
You never use Bipresic. We in remote places we regularly use Bipresic in blocks. In even dexamethasone we use in blocks.
Yeah. So dexamethasone, yes, many of them they use in blocks, but we have been used to using clonidine only, and most of the times we send the patients home in the evening. So we don't want the block to be prolonged. We give them oral analgesics and send them home. But for those who are admitted, yes, we use these adjuvants and then we put them on multimodal analgesic.
Thank you, sir. Thank you. I will conclude this session. This is one of the best topic, and I learned from a lot, and also our participant from you, like stalwarts in this field. I'm really appreciate your work as ISA India, ISA National, ISA from ISA also. You are doing very good job, sir. And for private forum point of view, also you mentioned about how is PNS and USG guided blocks, is what is the difference between them and where you need that. I'm
Yes.
really thankful, sir.
Yeah. Thank you very much, Sachin. Thanks a lot, ISA Nanded, and best wishes for your organization.
Thank you, sir.
Thank you, Sachin.
Thank you. So I'm concluding this session. Next time we will see Dr. Sunil Pandya sir on post-dural puncture headache on 2nd September. So please, guys, will join on next Friday. Thank you, sir.
Thank you very much. Bye-bye. Take care. Goodbye.
Bye.